Okay. Okay, welcome back. Let's begin our last session for today. And we have primary HSV. So we had many viruses causing infection, in the oral cavity. And then we had herpes simplex virus, varicella zoster, Coxsackie virus, type A, HPV, human papillomavirus, rubiola, Epstein-Barr virus, and then one of the retrovirus, HIV, causing oral infections. Then we had seen HSV type 1, type 2 has caused oral infection, but type 1 is more involved in causing oral herpes. And then we went to the primary HSV. So here, primary HSV varies widely in severity, increased with age. And the more the elder the patient is HSV, there will be more severity. It will be more severe. And then it's often subclinical, asymptomatic. In up to 80% of the patient is asymptomatic, but in such some severe cases, it will be very severe. In infancy, when the child is an infant, up to 1 year, is often mistakenly attributed to teething. The child has pain, and they think that it's because of the eruption of the teeth, but it's a mistake. So the physician should understand it can be due to primary HSV. Clinical features: a single episode of widespread stomatitis. There will be a single episode of widespread stomatitis. Unstable mucosa with vesicles which break down to form shallow, painful ulcers. Tender cervical lymphadenopathy. Under the cervical lymphadenopathy will be tender, right? Halitosis, bad breath, coated tongue. You can see the coated tongue here. Yeah, this is coated tongue, coated with vesicles. Fever and a general malaise, fatigue for 10 to 14 days. I should not say fatigue, it's a malaise. Although generally self-limiting, rare complications include hepatic encephalitis, and meningitis. You can say encephalitis or encephalitis depending on you. So the manifestation or complication of primary HSV is encephalitis, hepatic because of the herpes, and then meningitis. So it's easy to remember. You need to remember is usually asymptomatic in 80% case. If symptoms are present, signs and symptoms are present, it's severe. Mistaken of the teething in infants. Single episode, unstable mucosa with vesicles, tender cervical lymphadenopathy, coated tongue, resolves in after 14 to 15 days. Can lead to encephalitis. Next, primary HSV diagnosis based on the clinical features and history, although the virus can be grown in cell culture. So diagnosis is purely clinical, purely in the clinic or in the hospital, purely clinical. You see the clinical features and history and the eruption of the vesicles forming the ulcers later on, and the typical history of herpes simplex virus. Microscopically, ballooning degeneration of epithelial cells with intranuclear viral inclusions. So intranuclear viral inclusions are there. What are those? Let me go back. These intranuclear viral inclusions. These are the hallmark or pathognomic for HSV, primary HSV. And then there is a fourfold. Fourfold means 4x increase in the coalescent phase antibodies, which is diagnostic. So 4 times increase in the antibodies in the coalescent phase. Treatment, as you remember, there was so many stages: prodromal, coalescent, Okay, what is the treatment? Bed rest, topical and systemic analgesia, because there is pain. Sometimes we give some gel for the mouth, which gives some analgesic effect, some lidocaine, right? And then we want to prevent secondary infections, we give them gargles or mouthwash, chlorhexidine mouthwash or chlorhexidine gargling are usually adequate in healthy patients. But severely ill or immunocompromised patients should receive systemic acyclovir. How to give that acyclovir? 200 milligrams 5 times a day or 400 milligrams 3 times a day. Primary type and secondary type, or primary type 1, primary type 2. Primary type 1 usually asymptomatic in children. If symptomatic, it causes gingival stomatitis, vesicles and erosions. And then there is keratitis and vitiligo. Vitiligo is, yes, the same disease which appears on your fingers, lesions on the fingers, remember? And then genital type, primary type 2 cause genital vesicles and painful lesions. So type 1, primary type 1 or primary HSV is important for us as it is related to oral cavity causing gingival stomatitis. And the treatment is chlorhexidine mouthwash, bed rest, topical and systemic analgesia, and in severely ill patient, acyclovir. Okay, acyclovir. How to give acyclovir? This is the dose. Now, recurrent HSV, recurrent herpes simplex virus. As you already know, or you remember, that they get dormant in the dorsal root of trigeminal nerve, right? So, seen in up to 30% of patients. So, in 30% of patients of HSV, these herpes simplex virus will simply put, they hide, affecting the mucocutaneous junction of the lips, herpes labialis, and form the cold sores. Then it is a reactivation of the primary infection. The primary infection got reactivated, which is believed to lie dormant in the dorsal root and autonomic cranial nerve ganglia of trigeminal nerve. So it was hiding, it was dormant. Dormant means a pathogen which can cause disease, but it is not causing disease at the moment. It's hidden, it's dormant, it's not causing the disease in this state, the dormant state, the hidden state or the sleeping state. So how this dormant state gets started and cause a pathology is by either trauma, or by immunosuppression. So if there is a trauma or if there is immunosuppression, then these herpes simplex virus lying dormant in the dorsal root and cranial nerve ganglia trigeminal nerve, they come out and reactivate of the primary infection. Usually reoccurs in the area of distribution. So trigeminal nerve, wherever it supplies, it will, the pathology will be in that direction of the nerve supply. And then when you know one of the distribution, one of the branch of trigeminal nerves is involved, V, right? V, either V1, V2, or V3. Any branch is involved, then we know this is a branch restricted illness, and then we know maybe there is a chance of HSV. And then on diagnosis, on antibodies and labs, we can confirm HSV. Okay. Then we have a treatment for this recurrent HSV. Okay, sorry. The prodromal phase, burning and tingling over 24 hours is followed by vesiculation and pain. So there is prodromal phase, and after 24 hours, there will be vesiculation, vesicles will be formed, and there is pain. What is the treatment? Lesions, the rash may respond to 1% pencyclovir and 5% acyclovir if used in prodromal stage. What is prodromal stage? Before vesiculation and pain, 24 hours before, there is burning and tingling. And then history of primary infection. You say, okay, this guy has history of primary infection, not healed properly. Maybe the HSV is dormant in dorsal root, right? And should consider systemic acyclovir in immunosuppressed or compromised patient. Same as primary, the immunocompromised or the severely ill were given systemic acyclovir, same as that. And here we can also give the cream, so acyclovir. Remember that. Now we move on to the next virus known as varicella zoster virus, one of my favorite because this has basically two manifestation. Varicella zoster virus has two manifestation. Chickenpox as the primary infection. Those who have not read this before clearly and do not remember, please pay attention. Varicella zoster virus, varicella, chickenpox is also known as chickenpox as the primary infection. Varicella is the primary infection known as chickenpox. Remember like this. And then zoster is reactivation in the adults known as shingles. So in children, varicella, and then it will be latent, dormant, dorsal root, ganglion, and then in adults, reactivated. The reactivation is known as shingles. So varicella, chickenpox, zoster, shingles. It's like Z. If we do it like this, a mirror image looks like S. The zoster is shingles. Okay. Chickenpox. Let's start from the chickenpox in kids. Classically, an itchy, vesicular, okay, cutaneous to the skin, centripetal rash. What do you mean by centripetal and what do you mean by centrifugal? Centripetal rash means towards the body, and centrifugal means towards the periphery. Periphery means head and neck, face, arms, and legs. And centripetal means towards the body, starting from the body, the trunk, thorax, back, and then spreading towards outer side. Centripetal. Centripetal rash affects children with peak age of 5 to 9 years, rarely affecting the oral mucosa. So it really affects the oral mucosa, but it has some association in the oral mucosa. It can cause infection in the oral mucosa. That's why we are studying. Patients are contagious starting from 1st to 2 days before the rash until all lesions are crusted. Before this kid develop a rash, 1 or 2 days before, he is contagious. He or she is contagious and can spread. And the spread of this disease or chickenpox will be until all the lesions are crusted. You know, crusted, the hardening of the outer mucosa of the skin is keratinized and makes a crust. Okay. So here you can see there is varicella, and then there is zoster, and there is latent period. So varicella is shown in kids, zoster is shown in adults as shingles. And the acute complication of this varicella, bacterial sepsis, septic shock, death, pneumonia, encephalitis, hemorrhagic complications. That's why we are studying this, because this can cause this. And then acute complications, meningoencephalitis, myelitis, cranial nerve palsies. Cranial nerve palsies, why? Is residing in those cranial nerves. Latent, dormant there, can also cause palsies there. Vasculopathy, GI ulcers, pancreatitis, hepatitis, itis, pancreaso, and the liver, and GI ulcers. Remember. Now we go to the shingles part, second part. Previously, we have seen the chickenpox, right? Varicella part, the primary infection. Now we have gone towards the reinfection, zoster, shingles part. I'm trying to revise these terms together, not to confuse you, but to make you remember that zoster is shingles, related to shingles, and varicella is related to chickenpox. Common in immunocompromised, alcoholic, and elderly. So, and it's common, but I remember in my clinical practice, I have seen an adult, a teenager, I think 19 years old male. He had this distribution. He had a pain in stomach. He just had pain in stomach. He just came inside. He said, I have pain in stomach for 3 days and they are giving me medicine, but I'm not getting cured. and my professor, or you should say, he went for the abdominal examination and saw a rash which was distributed along the nerve distribution, you know. So he says, okay, you see this is shingles. I still remember. I can't find my mouse. What happened to your mouse? Come on. Okay. So this is shingles. Okay. Common in immunocompromised, but not only to here. And then alcoholic and elderly is confined to the distribution of nerve. So whichever nerve is involved, that nerve supplied to whatever part of area will have this manifestation. This virus will have this manifestation. There's usually a stripe of blisters and rash will be there where the nerve has supplied. Always present as a unilateral lesion, never crossing the midline. So it's on the one side. Always remember it's on the unilateral lesion on the one side. It then never crosses the midline. One of the very important hallmark characteristic of shingles. Facial or oral lesions may arise in the area supplied by the branches of trigeminal nerve. If this guy is hidden in trigeminal nerve, is dormant in trigeminal nerve, then whatever distribution is involved, according to that, the lesions will be formed. Do you remember our first slide? You remember our first slide? What was the first slide? Here we had HSV1, and oh, there's no varicella shingles. Okay, they should have shown it. So facial and oral lesions will be according to the supplied branch of the trigeminal nerve, either V1, V2, or V3. And then diagnosis. How we make diagnosis of shingles? Pre-eruption pain. Before the eruption of the rash, there will be pain, followed by development of painful vesicles on skin or oral mucosa, depending on the nerve involved, which rupture to give ulcers or crusting skin wounds in the distribution outlined above, whichever the nerve distribution is there. Here we see symptoms. We have pain, we have pre-burning, pre-eruption pain and burning, numbness, we have tingling, we have fever, headache, and fatigue. Shingles is a viral infection that causes a painful rash. Shingle is caused by the varicella zoster virus, the same virus that causes the chicken pox. Shingles can occur anywhere on your body, appears as stripe of blisters around your torso. This is a varicella zoster virus. The virus lies inactivate in nerve tissues. The virus may reactivate as shingles. The reactivation of varicella zoster virus, usually in adults, in immunocompromised, in alcoholics and elderly patients, is known as shingles. This disease is known as shingles. Okay. So you see, in early stage, we have some rash, blisters, which late stage we will have some crusting, and some of the 15% unlucky patients, the pain will stay there for a few years, known as post-herpetic neuralgia. Post-herpetic neuralgia, pain on the where the which nerve distribution was involved. Post-herpetic neuralgia usually clears in 2 to 4 weeks with scarring and pigmentation, and is often followed by severe post-herpetic neuralgia in up to 15% of the cases, which may continue for years. Very important, you can never forget this. Treatment: symptomatic relief for chickenpox. For chickenpox, you just give a symptomatic relief because it's good for the children, and as they will develop antibodies later on. And there is some evidence to suggest that aggressive early treatment of shingles with acyclovir, when within the first 3 days of the first vesicle, The first vesicle appear within 3 days. We have gone to a good physician. He has not been sleeping during the lectures, even in the minor subjects, and then he revised his varicella zoster. He recognized it as shingles and given him acyclovir. How many? 400 milligrams thrice a day or 200 milligrams 5 times a day, which decrease the incidence and severity of the post-herpetic neuralgia in immunocompromised patients. This acyclovir has decreased the incidence, mean new cases and severity of post-herpetic neuralgia. So if this guy or this patient was one of the unlucky 15% patient of this disease, shingles, which can get later on post-herpetic neuralgia, you can save them by giving acyclovir within first 3 days of the appearance of first vesicle. That is, if you have not slept during the lectures. Okay, so we had HSV, herpes simplex virus, type 1, type 2. Type 1 was important to us as it caused oral manifestation or lesions, whereas coated tongue was there. Then there was primary HSV, diagnosis, treatment, clinical features, and then there had a recurrent HSV because of the reoccurrence or reactivation of the primary infection, which was hidden in the trigeminal nerve or dorsal root ganglion. And then there was a prodromal stage 24 hours before the vesiculation, which was burning and tingling. And the patient also had a history which he so successfully informed you about, and then maybe you give cream, or this is recurrent HSV. And then we went to varicella zoster virus. This is one virus, this is not two viruses. This is the name of a single virus causing chickenpox as well as shingles. Chickenpox usually in children as primary infection, varicella infection, and then shingles is a reactivation of that hidden or dormant or latent virus, the same virus, varicella zoster, and causing shingles in usually in adults and elderly patients. Okay, perfect. And then we studied how chickenpox and shingles are different, and what is post-herpetic neuralgia, and what is the treatment of these. And then there is another, you see, herpes virus, varicella zoster. We have varicella zoster virus here in dorsal root ganglion. Initial infection with virus usually during childhood causes chickenpox. You know this. This causes chickenpox. During childhood causes chickenpox. Then the virus then moves to the dorsal root ganglion. What is ganglion? Do you know? This root ganglion, where it remains latent indefinitely until a situation comes. What situation? It can be immunocompromised. How immunocompromised? It can be as simple as diabetes or obesity. Some of us not take our health, obesity, overweight, or increase HDL, eating fast foods every day. Yes, it can reactivate. Until that, it's remain latent in the dorsal root ganglion. And then later, usually in adulthood, immune system depressed, immunocompromised, immunosuppression, anything, or stress. Okay, some guys are taking that, okay, how are you gonna pass this dermatology? Relax, you will. Just pay attention in class. Don't take stress, otherwise shingles can happen. Yeah, because this virus, varicella zoster, was lying latent, lying dormant here in dorsal root ganglion. Later, your stress can trigger a reactivation of the virus, the same virus, varicella zoster virus, and will cause shingles because now you are adults. Signs and symptoms: tingling, burn, pain, itching, fatigue, sensitivity to light, headache, and blistering rash, burning pain, tingling. Yeah, something is wrong. And then we have a vaccination known as Zostavax against shingles. One dose only. And if you want treatment, the medicine Appearance of the first vesicle within 3 days, give acyclovir. And if you are pregnant, you know, contraindication, go to your doctor. Okay, perfect. Now we have some idea of HSV and VZV. Now we go to the third virus, Coxsackie virus, causing herpes angina, Coxsackie type A virus. Herpes angina is caused by Coxsackie A virus, is confined to children. How it is different from the tongue coated one? Which was the tongue coated one? Remember? This. Here is the tongue. Coated tongue. Primary HSV. You see the difference. Primary HSV, primarily coated tongue. Everything else is spared. The mucosa is spared. Usually it's on the tongue. Coated tongue, HSV. Coated tongue, HSV. And tongue is spared. It's on the fauces. It's on the uvula, on the palate. Tongue is spared. No coated tongue. Coxsackie A, herpes angina. This is caused by Coxsackie A virus in children. Widespread small ulcers on the oral mucosa with fever and generally upset patient. Clinically, it resembles with herpetic stomatitis, also known as gingival stomatitis, also common in children. Also common in children. So a person comes in, shows you lesions, coated tongue, herpes simplex, maybe herpes simplex. You get the scraping test, you scrap it, you know. And maybe the coated tongue is not there, the tongue is spared, you see the mucosa, ulcers, lesions, palate, uvula involved, herpes angina, Coxsackie type A. It may be preceded by sore throat and conjunctivitis. So maybe there initially some sore throat in the patient, or there is conjunctivitis, redness of eye and inflammation of conjunctiva. After that, there can be Coxsackie A virus causing herpes angina. This is as same. Why I'm relating to that? HSV was also mistaken for the teething in children, in infants. This can also be mistaken for as teething process or eruption of teeth in children. HSV, herpes angina. I'm pushing here. I'm putting some pressure because it's important. We love viruses because we always forget them. We never remember them. That's why we love our viruses. We love our bacteria. But we still thankful to our fungus. Azoles, not a lot of antifungals. Azoles, buconazole, right? But we still remember, but we still love our viruses more than our bacteria. Cyclovirs, it solves a lot of problem. Gancyclo, penny, and acyclo. But then bacteria are a lot and their antibiotics are a lot, right? That's why we have to love our bacteria the most, because it's difficult to remember, yeah? So clinically, it resembles herpetic stomatitis. Everyone back, right? Clinically, it resembles herpetic stomatitis. But the common sites involved here are uvula, palate, and fauces. These faucets, remember platoglossal folds, then platopharyngeal folds, platoglossal, platopharyngeal, and then fauces. The pillars of oral cavity. I hope you remember fauces with no gingivitis. So there is no gingivitis. The gums are okay, and then these lesions or ulcers are present at uvula, palate, and fauces. It may be preceded by sore throat and conjunctivitis. Can also be mistaken with as teething, as same as HSV. Self-limiting in 10 to 14 days, same as HSV. Spread by fecal-oral route. This is spread by fecal-oral route, whereas HSV1 was limited to the mostly in the oral cavities, spread by saliva kissing, sharing drinks, and then HSV2 was genitally available, so usually primarily spread by sexual contact. Herpes angina or mouth ulcer. What is this disease? This is an acute, self-limiting viral illness. Acute, self-limiting, 10 to 14 days, viral, Coxsackie A virus, type A. Characterized by multiple painful blisters in the mouth that usually last about a week. Which part of mouth? Palate, uvula. Tongue is spared because tongue was not spared by HSV1. Tongue is spared by herpangina. So herpangina says, Coxsackie type A says, okay, mine is the palate, the floor, the roof of the mouth. And HSV says, I'll coat the tongue. I will coat the tongue with lesions. What are the symptoms? Painful blisters, headache, sudden high fever, drooling, all the prodromal syndrome symptoms. You know, prodromal syndrome. Treatment bring lots of cool fluids, treat fever, oral lozenges for pain relief in the pharynx, bland and cool diet, not so hot, not so spicy, and then ice creams to keep it cool because everything is burning, is painful blisters. When the mouth has blisters, when there is teeth, people love ice cream because it keeps everything cool, right? Okay. What is the role of antibiotics here? This is viral in origin. Antibiotics are useless. Prevention, correct hand washing technique. So it spreads through oral, orophycal, fecal-oral, whatever you want to say. So everyone needs correct hand washing technique. Surgeons, you are spared. Physicians, please follow. Vaccines, no vaccine available for this yet. So you have to suffer for 7 to 14 days, 10 to 14 days. So make sure you fecal-oral route, you take care of the fecal-oral route, correct hand washing technique. I'm trying to make you remember. And then because there is no vaccine, so otherwise 10 to 14 days. And it's painful. It's in the mouth, sparing the tongue, because tongue was covered by HSV, herpangina, mouth ulcers, perfect. We keeps, with this treatment, we keeps things cool. And then Coxsackie virus A16, but less commonly type 5 and 10, cause hand, foot, and mouth disease.